We are live now. With all your permission, I'm starting this session. A very good evening to all. I am Faraz from IJCP Group. I welcome all the participants on today's panel discussion on a topic Alzheimer's disease through a holistic lens. Let me tell you overview of the topic before starting this session. Comprehensive and holistic perspective on Alzheimer's disease in the enlightening webinar. Alzheimer's disease is a complex and neurological condition that impacts not only on the affected individual, but also their caregivers and the broader community. In this webinar, it has shed of light on the manifested effects of Alzheimer's by examining it through a holistic lens, considering not just a medical dimension, but also a emotional, social, and caregiving aspects. So before starting this webinar, I would like to introduce the moderator and the guest for today's session. Let's welcome today's guest with great honor, Dr. Ananya Sinha ma'am. And let me share some of the achievement of the ma'am. Ma'am has done MPhil in clinical psychology and PhD. And she is the founder and director of chief clinical psychologist of the Therapal Health Private Limited, a global mental health care service platform. She is a RCI registered trauma-informed LGBTQ affirmative clinical psychologist with over 13 years of experience. And she is also international affiliate member of the American Psychological Association, that is APA, and a member of the Global Clinical Practice Network of the World Health Organization, and also a member of a Society of Psychotherapy Research Europe chapter. And she has extensively worked with a multicultural client and specified in the conjugative behavior therapy, dialectical behavior therapy, trauma-focused work, couples therapy, and LGBT affirmative therapy. She has written a book chapter, published her research in international journals, and have been invited as a speaker in multiple international conferences. She had served as a clinical psychologist in the Damdam Central Corrector Home, West Bengal, in a multiple mental health clinics. She has also held teaching position as Christ University, University of Calcutta, and Indian Psychoanalytical Society. She has been quoted in the Telegraph, Economic Times, and the Wired's Parent Circles, News Laundry, and the like. Now I would like to invite the guest for today's session. Let's welcome today's guest with great honor, Dr. Dipanjan Banerjee, sir. Sir is a consultant neuropsychiatrist at Apollo Multi-Specialty Hospital, Kolkata, co-chair advocacy and public awareness committee, International Psychogeriatric Association, that is IPA. And our next guest for today's session is Dr. Muhammad Idris Sharif, sir. Sir is a family medicine specialist at Daman Healthcare Assurance Hospital Company, Kuwait, and Academy of Family Physician of India, and Indian Doctors of Forum, Kuwait. And our next session for guest for today's session is Miss Sayantika Mukherjee, ma'am. Ma'am is a consultant clinical psychologist, Therapal Hill Clinics Global Health Hospital. And our next guest for today's session is Miss Archana R, ma'am. Ma'am is a consultant clinical psychologist at Therapal Hill Clinic. Now I would like to invite and hand over this session for the moderator of this session, Dr. Ananya, ma'am. Ma'am, over to you, ma'am. The stage is yours, ma'am. Kindly proceed from here.
Thank you, Faraz. Thank you for the warm welcome, and a very warm welcome to our distinguished speakers. It is our great honor to have Dr. Muhammad Idris join from Kuwait to our program today. Dr. Debanjan unfortunately stuck in an OPD work. He will be joining us soon. And it is also our great pleasure to welcome Shayantini Mukherjee and Archana Ratnavalu, who are all members of therapy team, and Shayantini is also associated with Clinicals Global Hospital. A very warm welcome to all of you. And let's start today with our very important discussion on Alzheimer's. It's only on days like these, like which is World Alzheimer's Day, like today, that we feel that we need to create awareness on issues like Alzheimer's. People often try to get a lot of information online, or they always do not know what exactly are the early signs and symptoms, when to go for checkup, how is the usual diagnosis process like, the intervention, how does it look. So we will try to cover all of them in bits and pieces today. So to start off, Dr. Idris, if you can tell us a little bit about, what is Alzheimer's disease? If you can introduce us to the disease, the signs and symptoms of Alzheimer's.
A very good evening to all of you, and it's wonderful being here with all this guest list that we have today. A very important topic which Dr. Anya has asked us to speak about on a very important day. Thank you for taking this initiative. So, Alzheimer's has been around for a long time. Uh, we have seen it, experienced it, but yet sometimes we feel we don't know much about it. And it's also because of many sociocultural barriers. Uh,
Mm,
there are societal barriers, there are information barriers, which, especially when you come from a place like our South Asian region, India,
mm,
Pakistan, Bangladesh,
mm,
where awareness about health in general is lacking. So to
mm,
have specific awareness about diseases, unless we really make efforts to make this happen, it's not going to be there. So
mm,
Alzheimer's has been one of the major issues, especially with the geriatric population. By geriatric, I mean, uh, as per the diagnostic criteria, 65 and above is where we see this more often.
mm,
But it is not uncommon to find this earlier. There are definitely a few cases where it can happen earlier. The latest, which has been reported as per evidence, is 43 years old. There are multiple varieties of Alzheimer's. So the most
mm,
common thing that we tend to see, and the most common is, periods of memory loss. People
mm,
having suddenly finding themselves in a loss of words. They're speaking a sentence and they suddenly forget something in between. They're not
mm,
able to bring that back. This
mm.
happens to most of us as well sometimes, but
Yeah.
those are sporadic events. They're not consecutively happening with us. It may be because we are stressed, maybe because we haven't slept well, it may be because we've had certain emotional triggers around us. But
Mm,
when we have these consistently happening over a period of time, and they have been getting worse over a period of time, that's when we start suspecting that maybe
mm,
this is Alzheimer's. So,
mm,
as we know, in common man's language, we can say that it's a syndrome of memory loss and various other cognitive dysfunctions associated with memory loss. But I think what we can relate to as common people is, memory loss, loss of recent events which have happened around us, something that I may have learned recently, but I'm not able to recall. And this consistently over a period of time is what we are more interested to take as suspicious as that.
mm,
So to
mm,
sum it up, anybody with the age group of 60 and above facing consistent of issues, I think it's about time we start letting people know that you should think Alzheimer's unless
mm.
you rule it out.
Right. Thank you so much for giving us an overview of what Alzheimer's is. So there is often an association between age, and since you mentioned age, so there's often an association with people who are in the elderly population who are above a particular age range. They only can have Alzheimer's. Is that a correct notion, or younger people can also have Alzheimer's?
The latest evidence have actually categorized Alzheimer's into a few categories. The most
Mm,
common one is what we call as typical Alzheimer's, in which C and above is what we see as the peak incidence. And anybody who is
mm,
16 above, the incidence and prevalence seems to increase every 5 years beyond 60. So that's the
mm,
majority of people who fall under Alzheimer's. The next category is an early onset Alzheimer's, which can happen
mm,
in people less than 65. This is about 5% of the overall Alzheimer's diagnosed across the globe. And one of the
mm,
main symptoms which people come here at this category is a decrease in job performance. That's the
mm,
major concern. I was doing this so well, but now I find it difficult.
mm,
It may be things to do with simple cognitive behaviors, simple personality changes, which people find it difficult to fathom and accept that this could be something else. So that's
mm,
about 5% cases. And there are certain
mm,
other atypical symptoms with these people. They may have a language barrier, like I mentioned, they are at a loss of words. They are
mm,
speaking sentences phase out.
mm,
It's like a blank.
mm,
They know what they want to say, but they cannot find the right word. That's one of
mm,
the things. Mood changes
mm,
are very common in such people.
mm,
Uh,
mm,
and apart from the situation of a classical memory loss, it doesn't happen in atypical patients. The most
mm,
common thing, again, as I mentioned, is something which I was doing consistently, I'm not able to do now. or
Hmm.
lack of performance.
Hmm. Hmm.
Last but not the least is the inherited patterns of Alzheimer's, wherein it can be a further lower age group again.
Hmm.
But this is just 1% of the total diagnosis we have
Hmm.
documented across the
Hmm.
globe. So this the most youngest patient we have documented is one of 43 years old in this case,
Okay.
and that's an inherited case.
Hmm.
However, I would like to mention a very important aspect here, which happens in Down syndrome.
Hmm.
People with Down, they have abnormal chromosome.
Hmm.
It's called chromosome 21 defect,
Hmm.
trisomy defect, wherein the genetic defect is
Hmm.
onto the normal
Hmm.
chromosome. So typically, people with Downs, they tend to have Alzheimer's kind of patterns 10 to 20 years younger than the normal
Okay.
population.
Okay.
So that's the interesting fact I gathered from
Hmm.
some recent
Hmm.
evidence and papers. But
Hmm.
that's something which we will have to keep our eyes open to, because Downs is still around us. Though not very common, it's there and it's a challenge. So
Right.
managing Downs itself is challenging, but managing Downs with Alzheimer's is going to be more challenging. So keeping our eyes open to these probabilities, I think it'll help us to pick them up early.
Right. Right. So thank you, Dr. Idris, for giving us an overview of what Alzheimer's presentation looks like, and also giving such interesting fact that I think many of us did not know that it could start early, and particularly when somebody has Downs, then it can start much earlier. So moving on to Dr. Devanjan, I'm glad he has been able to join. So hello, Dr. Devanjan. So
I'm sorry to everyone that I got late. I thought I kind of joined 4, but then, today's been a busy day and OPD was quite hectic. So I'm glad I could finish wrap up and join you. Glad to see you again. Glad to see everyone. Hi.
So, Dr. Idris just gave us an overview of what Alzheimer's presentation looks like. You have been working with patients with Alzheimer's for a very long time. If you could tell us, when is a time when one should go for a checkup? Like, it's, as we can see that some of the symptoms are like quite minor, right? Like there can be memory losses, which, like, I'm not being able to remember something that can happen to anyone. So when is that time when one should go for the checkup? And what actually happens biologically, what happens in an Alzheimer's disease?
Thank you, Alina. So, uh, good evening, I guess, to the audience. And I'm sure that, this discussion, thank you for having this discussion. I think we were just discussing today morning that based on the present World Health Organization data, roughly 1% gets diagnosed with dementia every 3 seconds. And that's concerning. I mean, just in terms of sheer numbers. India is anyway a very fast aging population, so we do expect that individuals living with dementia will gradually increase. So I think the discussion becomes very relevant. I'll answer your second question first, and then I'll take the other one. So what happens in Alzheimer's biologically, if I can just explain it in very simple terms to the audience. So an adult human brain weighs around 1.5 kgs. What happens both in terms of structure and function of the brain is that it starts declining due to certain abnormal processes that start happening within neurons. As a starter, there is something called A beta, which can be considered to be an abnormal protein. And that is normally cleared by the system that we have in our body. Like our kidney clears toxin, it is cleared by the lymphatics. Reduced clearance and increased production, both of which can actually lead to deposition of this abnormal protein in certain parts of the brain which are responsible for memory, thinking, and other cognitive functions, particularly in the temporal lobe, the portion that is here in our brain. And eventually, with that deposition, like any other reaction, the body calls upon the immunity, the inflammatory cells, and they ultimately, in this whole process, the neurons get destroyed. So that's the gross part of it. But then what happens is, in terms, if you actually look at it through a deeper lens, our neurons are wired very tightly. It's like this. And what happens is it gets loosened up. And that's the basis of all information processing in the brain. It all depends on the density of the nerve connections, which we call as synaptic density. That gone, ultimately, it's a downward cascade. Now, what's interesting is that the prevention of Alzheimer's doesn't start at 60. It starts when a person is born. So it's a process that's the illness probably starts affecting at around 55, 60 years, as Dr. Idris was mentioning. It has a genetic basis at times, increased prevalence in downs. But today we know that the process which leads to illness must have started 10, 15 years even before the first symptom ever appeared. And that window period, nobody will be knowing that, this person is probably going to get affected with dementia. So prevention becomes extremely important in this illness because it is chronic, it's degenerative, and there is no actually reversing medications. Your first question as to when should we seek help, this entirely depends on what we are looking at and the context. Somebody who has been a shopkeeper the whole life, not able to do a simple calculation, will raise an antenna. Somebody who has been working in farms, and is not able to identify his or her bullocks will raise an antenna. Somebody who has been in a very intricate multitasking profession today is not able to remember the list in a market should raise an antenna. So what I'm trying to mean is that it depends on a person's daily routine, the context, what the person has been doing, and what he or she forgetting or missing out on. In general, when we discuss Alzheimer's, a lot is about memory. But it's not just about memory. When people come and tell us, okay, he's forgetting, she's forgetting things. But that's not all about it. It's about multitasking problems, which we call as executive functions. It's about finding sense, which we call as perceptual functioning. It's about understanding and reciprocating social behavior that we term as social cognition. Language perception, that I'm communicating, I'm able to understand what you are telling, and learning. So not only memory, but able to learn a new information and process it. This all functions are function of the brain. So it's not just about memory. Any change in a person's daily life, be it remembrance, be it social behavior, be it sudden emotional changes, that interferes with their personal or professional life, I think should be the reason of concern where a person needs to take help. And off context here is the theme of this World Alzheimer's Day, that it's never too early, never too late. I will tell you for seeking help. It's never too early, it's never too late.
Right. It's never too early and never too late. So thank you, Dr. Debanjan, for emphasizing the need to actually act as early as possible, and for telling us in such lucid language what exactly happens in Alzheimer's. So now we have an idea of what the presentation is like and what the biological aspect of Alzheimer's like. I'll move on to Archana. If you can tell us a little bit about the psychological aspect of Alzheimer's or the psychological presentation of Alzheimer's. I think you're on mute. You're not audible, Archana. Can you try for us? Can you help her? Is it work? No, it's not working. I think there should be an option of mute, and beside that there should be an arrow upwards, and there you need to select the speaker.
What about now?
Now it's audible. Yeah. But it's still not very clear. Can you try speaking a bit louder?
Is it clear now?
It is still not very clear. What about others? Is it audible to others?
If Archana, you can use a headset, I think it will help because it looks like it's not capturing the audio from a distance.
So while Archana is checking her microphone, Shantani, can you also check whether your voice is audible?
Am I audible? Yeah.
Yeah, you're audible. Yeah.
Okay.
From my side?
It's better. Let's go ahead with it. If you can try and speak as loudly as possible. Yeah.
Yes, I will. All right. So first of all, thank you, Dr. Ananya, and thank you, IGCP, for organizing such a discussion on a very important day. So to give you an overview from a psychological perspective, so there are several challenges can be identified throughout the course of Alzheimer's disease. So it's not just like one thing is being carried out throughout. So because Alzheimer's has different stages. So every stage, starting from the diagnosis level, from screening level, then to the initial stage, then to the moderate level, then at the severe level, several psychological issues do come up for a patient, him or herself itself, and then for a caregivers too, or to the family itself, because the entire diagnosis and the well-being of the family and also the patient's welfare kind of changes. So every stage, both the family and the caregivers kind of take a position to change and go through the transition. So to highlight some of the aspect or some of the psychological issues that a person with Alzheimer's start from is it's very different. It's different from one person to the another. Not everyone have a same perspective. So first important thing that's been noticed, especially for a initial level, is like a decline in memory. As other doctors also mentioned, decline in memory is one of the things, which also includes the aspects of cognition, such as they have a word finding difficulty, they have a vision and the spatial issues. That's some of the things that usually start with, and they will also notice that there are changes in their ADL activities too. When in the initial stage, it starts with some of the issues they come up is like wandering. They have a feel of getting lost. When it happens, it becomes a issue for the family and also for the caregivers too. Okay, what's happening? What is happening at myself? The client myself also will be confused. Why am I not able to do it? So that's one of the aspect that comes in. And they have issues with like handling the money, especially as Dr. Dipanjan pointed out with a shopkeeper. Then they having noticed the issue in handling the money, paying bills, then it becomes a challenge for them. Sometimes in order to process it, they kind of ask questions repeatedly. That's the other thing they will have it. And their daily task can be even more challenging. And they may have a behavior and also a personality changes. So as Alzheimer's progress in the moderate level and other things, there can be damages in regard to their language, in regard to their judgments. And also sometimes their sensory processing can also becoming an issue. So that's where they become even more dependent on the caregivers and the family. Of course, certain rehabilitation do help us, but these are some of the things that they have it. And they become severe. They are completely dependent on the family or the caregivers. So when it becomes severe, mostly the work or the psychological understanding of the caregivers is important, and that is something we have to be focused on is behavior. Other than this, they also have certain issues of depression, apathy, agitation, and an aggressive behaviors or certain psychological components and the personality things that they develop within Alzheimer's clients. Yeah.
Thank you, Archana, for summarizing the psychological aspects of Alzheimer's. And like you lastly mentioned about depression, apathy, I'll now move on to Shantani. And if Shantani can tell us a little bit about the associated behavioral symptoms. So like we know that there are certain presenting symptoms, like we know that, okay, if the person is not being able to do certain things, not being able to recall certain things, not being able to manage let's say monetary things in a particular way like he used to do earlier, what are the associated behavioral issues that we need to be aware of?
Okay. Hi. Am I audible? Yeah.
Wow.
Okay. First of all, thank you for inviting me and feeling very honored and pleasure to share the platform with some esteemed members. So yeah, I agree with Archana in most of the times that whatever she has mentioned, that along with the core symptoms of Alzheimer's symptoms, the psychological and the behavioral aspects sometimes go hand in hand. You cannot just separate them. So the comorbidities which she has also mentioned, like depression, anxiety, apathy, temper tantrums, aggression, irritability, frustration. Sometimes it is also accompanied by certain psychotic spectrum symptoms, like suspiciousness, delusions, hallucinations, etc. But let me highlight something here before going to any further. As Dr. Debanjan has also mentioned that there are different stages of Alzheimer's are there.
Mm.
And symptoms suddenly deteriorate with the stages. So whatever I have seen in my clinical practice, the early stage of Alzheimer's is mostly concerned with the neurotic symptoms like anxiety, depression, agitation, aggression. As the stage progresses to the middle and the severe stage, the symptoms worsens along with the psychotic symptoms. So if anyone asks me what can be the reasons behind these symptoms, well, there are n number of reasons. First is what Dr. Idris and Dr. Debanjan has highlighted, as obviously Alzheimer's is a neurological disease. So functional and structural changes in the brain happens, changes in the neural connections, neurotransmitter imbalance happens, which may lead to certain psychological and behavioral symptoms. Number two is certain communication challenges. Like the doctors also said that they know what to say, but they are unable to express their feelings through words. So automatically, if we think and empathize with an Alzheimer's patient, I don't know what to communicate to others. This becomes a challenge. And slowly it leads to certain behavioral and psychological disturbances. Next is environment, the current environment they are living in. Like, is it like temperature is too hot or too cold, too loud, too quiet, lack of good structure of routine, etc. like that. Certain physical changes within them, which they are unable to communicate. Because I have also seen in my clinical experiences that if they are experiencing certain pains in their body, that is also they are unable to communicate to others, which is eventually making them frustrated, agitated, aggression, sometimes crying also, uncontrollable crying. Okay. And lastly is unmet social and emotional needs. That is, I have seen myself working and being capable for the past most of the years of my life. Suddenly, I'm having a sense of loss of control. Suddenly, I'm feeling bored. I'm unable to connect with people. Feeling of worthlessness, helplessness. All this slowly starts gathering. And I remember one of my patients in the early stage of Alzheimer's, he told me once in the hospital that, doctor, I was able to function even 1 year back. So now I'm unable to function. He was slowly developing so much excessive self-doubt that self-doubt is pushing him towards anxiety and depression. So yes, these are certain very sensitive issues we need to handle.
Right. Thank you, Shantini. Thank you for highlighting that Alzheimer's is not just the symptomatic presentation, it is also the associated feelings. There are impacts in other areas also, which as a mental health professionals, we need to keep in mind and keep as a part of our intervention plan. Are there any myths associated with Alzheimer's?
Yeah, actually, Dr. Idris has already highlighted one myth. I think that old age, does it only happen in the old age population or not? But yes, like other disorders, there are obviously certain myths which I have seen, and through researches, it has also been seen. First question I always come across is Alzheimer's and dementia are the same? So yeah, the answer is no. Alzheimer's is a type of dementia. There can be many other types of dementia, like vascular dementia, Lewy body dementia, frontotemporal dementia. So another question I come across as a myth is Alzheimer's always very genetic and nothing can be done about it? Again, the answer is no, it is not always genetic. Many researchers have actually shown that our early lifestyles and our environment can also lead to this disease. Another myth I sometimes come across, is it very life-threatening or very fatal? Well, again, the answer is no. Many patients with Alzheimer's live a very long life. You just need to approach with a proper treatment. And obviously, it doesn't only affect the older generation, and Dr. Idris has already mentioned. And lastly, one myth which is very frequent, that can I cure it completely? Well, very sadly, the answer is no. But science is advancing. Let's hope for the best. Maybe in future, there is a permanent solution for Alzheimer's. I'm hopeful for that. But currently, no. Only the preventive measures are taking And we are slowing down the deterioration process basically through medications and through rehabilitation process.
Right, right. Thank you, Shantani, for beautifully highlighting the myths and also clarifying the myths, busting the myths for us. Dr. Debanjan, you must have seen a lot of caregivers also, like not only patients, but caregivers. We often see that these are myths that people in layman often have, and that also that comes out in their behavior and their action, and the way they're treating the patient. What kind of challenges as a doctor you have faced when caregivers have such myths, and how does that come into the intervention space?
Yeah, thank you. So I think that's sorry, that's a very common problem that I think all of us who work in this profession has faced. I would say the first thing is understanding that the person has an illness, because you know when a person is no more, when you're grieving a person, it's that the person is no more, not existing. But dementia is a kind of condition where you lose a person even while he or she's alive. And you lose a person's behavior, identity slowly in front of your eyes. I mean, there's a personal connotation to that. My granddad had Alzheimer's, and I kind of started seeing him when I was nowhere near MBBS. I also saw him as a doctor, so I can understand the differences, how I felt. Now, he had this very funny habit of carrying me on his back when I was a kid and moving around. So that was, of course, something which was very close to me. Now, at the kind of when his dementia progressed, there was a time when I used to go hold his hand and even kind of just pat him on his back, that kind of relationship that we shared. But then he was no longer able to understand that. And that's where it hits hard. When you see a person who is, the same relationship dynamics doesn't work out anymore. Now, this is one side of it. Imagine when this also happens to a spousal relationship, because I know individuals who, let's say, a 83-year-old person is taking care of a 78-year-old person. Even probably more ironic, 85-year-old mother is taking care of a 65-year-old son. And these are not uncommon. So it's not that just because of age, Alzheimer's will happen. I think the primary challenges that we face with caregiver is what we start with, like the typical grief reaction of denial. That's the first thing. So that's probably one of the reasons why aging is also normalized across spectrums. And it also depends upon when the person is brought to us. Mostly, if a person forgets, nobody will bother to bring the person to medical care. It's only unless they start, getting irritated, throwing things, hallucinating, running out of the house. That's when usually the red light flashes and people bring them to us. So I think the first challenge is that. The second, the other things that come into picture is monitoring the treatment. What happens in these cases are the behavioral problems that I think Archana and Shantini, both of you, very nicely mentioned. Behavioral problems form a very important core of the entire management, and they can become very problematic. But what I always feel is that adding a medication never resolves it. But the caregivers try to think in that way, that just give us a medicine and so that the person is relaxed. Because honestly, if I am in their place, I would want the same. But the problem is that multiple medicines only worsen the condition. Imagine somebody who is having constipation, pain, fever, not able to express because of cognitive difficulties. How will an antipsychotic help in anything? Somebody who is on, get a bunch of medications, 4 different multivitamins from 4 different consultants, and the person is taking everything. Literally, every single molecule that enters human body has a repercussion. So sometimes only that we need to do is what we call as de-prescribe, stop. The other thing is, imagine if I have dementia and I am not able to understand the other side, what's happening. Many people will be reluctant to take baths, do the daily activities, So I can just understand that some person is randomly coming and pulling my clothes and shoving me inside the bathroom. So if I don't know what is happening, won't I get agitated?
Hmm.
If
Hmm.
anybody pulls at my clothes, won't I get agitated? So that's a problem, and that's something which is very difficult to make the caregivers understand as a clinician.
Hmm.
And even when you tell about, it's easy for us to spend 10 minutes, 30 minutes, tell them about what needs to be done in terms of non-pharmacological measures. But since they are so individualized, abstract, and contextualized, it's
Hmm.
very difficult to follow up whether that exactly is being done in the particular scenario. And that I would say is a big challenge that I have faced and keep facing in my regular practice.
Hmm. 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 So I think thank you, Dr. Debanjan, for bringing this out so well, that it is a loss at multiple levels. We when we think of Alzheimer's, we just think of Alzheimer's as a disease which has a particular set of symptoms, and that is how our understanding ends. The way our conversation is moving, I think now we can see what a person with Alzheimer's might be going through. It's a state of complete chaos. Things like you are also grieving parts of yourself. I can't do what I could do earlier. Everything else is chaotic. It's so confusing. It's threatening at times. I'm feeling unsafe. I'm trying to make sense of things, and I'm reacting to that. And if I extend the space now and bring in the caregivers in this space, the caregivers are also going through the same confusion, but they are now thinking that, usually what I have seen also, caregivers saying, why are you doing it? The usual response is, why are you doing it? Why can't you just sit like this? Why can't you remember? Why are you shouting at us? So that also is a response to their frustration, because they are also not being able to make sense of the huge change that is coming to a person who they have known so differently.
I will just mention a point here. Besides so many whys, I think the other why is why me or why them.
Yeah.
So it's like everybody gets wet in the rain. Why did I catch a cold?
Yeah.
So it's
Yeah.
like that. I mean, I feel that because I also used to feel that why my grandfather? You know,
Yeah.
not this
Yeah.
could have happened to any other person. So that is, I think, some place where it's a process, and all of us are involved in that with the caregiver throughout their journey. It's
Hmm.
not a one day thing, but I think it happens over a period of time.
Right, right. Absolutely, absolutely. I think why me is a question I'm also seeing certain overlaps between grieving. Like when we grieve, also we keep asking why me. So there are some patterns. Uh, Thank you, Dr. Debanjan, for highlighting this very important aspect. So, Dr. Idris, what is the usual way by which we assess or diagnose Alzheimer's?
Thank you. It's been a great discussion all across with multiple facets of looking at the same condition. So, coming to assessing and diagnosing these conditions, um, typically, as I mentioned to you earlier, it all begins with one or two symptoms which indicate that something is not right. And then
Hmm.
when these symptoms consistently happen over a progressive period of time, progressive loss of memory, a progressive loss of a particular act, which I'm used to every particular day in my
Hmm.
life in the past, let's say, 2 to 3 decades.
Hmm.
And over a period of time, these things start, building, and people around you start noticing it as well. So
Hmm.
those are the times where I think we could step in and start screening these people for these kind of situations. Are we looking at a dementia of Alzheimer's kind, or we have something else? So
Hmm.
typically, it involves a varied way of assessing. We do a cognitive assessment, we do a psychosocial assessment, we do neuropsychiatric assessment. So all these put together will help us to diagnose whether we are looking at Alzheimer's in the first place.
Hmm.
There are certain investigations which can help. MRI has been known to show certain changes which are very typical of Alzheimer's. Of
Hmm.
course, PET CTs and various other CTs have also come up, like amyloid CT. These things help to diagnose specific types of Alzheimer's, which are
Hmm.
familial. Like I mentioned, the one which has autosomal dominant pattern of inheritance. There's a
Hmm.
genetic defect.
Hmm.
So apart from these, typical lab tests or genetic tests are not of much value for
Hmm.
diagnostic purposes. But once we have a diagnosis based on the cognitive assessment, neuropsychiatric assessment, and the social aspect of getting the symptoms from the patient himself and from the caregiver, which still forms the major basis of how we diagnose it. Because until we know the story of how it began, it's very difficult to comprehend what we are dealing with. So once all these fall into place, uh, the genetic testing will add value to it. But without the history, without the background, without understanding what cognitive dysfunction he's facing or what cognitive impairment he's facing, how the neuropsychological aspect of his life is shaping out, just a lab test or a genetic test will not be of much value. So the whole onus will lie on how we are able to gather information, how we are able to process that with help of various other specialities, like I mentioned earlier, psychologist has to be there, a neuropsychiatrist may be required to evaluate the patient, and the whole social history, which is typically gathered by the family physician in this place, who's been seeing this family for a long time. He suspecting this in the first place will be the first step. And then the whole team fits in. So this is in brief about how we assess the case and how we go about diagnosing this condition as well.
Right. So what you're saying is it is not just the presentation, and there are no such diagnostic tests per se. It is more about having a very thorough understanding of the development, the history, the overall conflict, like basically understand its story of the patient and understanding the history of the development of the symptoms really well. And then only we can come to a final conclusive diagnosis.
Absolutely. Like Dr. Dibanjan earlier mentioned, that the process would have started much earlier than the presentation. So the first person to pick up in an ideal situation will be your family physician who's known you for decades. He's seeing things and he's seeing things developing over a period of time. So that's about the assessment. Diagnostically, I think we would rely on certain tools, which are diagnostic criteria. The most common ones is the National Institute of Aging and Alzheimer's. They have a very set criteria, which has shown consistent, accuracy in its criteria. Based on these criteria, we decide whether the patient falls into the Alzheimer's category or not. Like most of you are aware of the DSM-5 category, which was again updated into 2017, I guess. It has not been validated as much as the previous one, but yes, more or less the accuracy seems to be almost the same. I think Dr. Dibanjan can add more to this when his turn comes to this. I would stop here.
Thank you, Dr. Idris. Dr. Devanjan, would you like to add something to that?
Yeah, I mean, what Dr. Idris was mentioning, I think is very relevant in terms of how we go about assessing a person. Also, it's not a cross-sectional snapshot issue. We assess over a period of time. Getting information from the caregiver is important, but at the same time, I think getting to know how a person, himself or herself is experiencing is also important. I would actually, so this neurocognitive assessments, my team has conducted workshops at multiple places. The feedback that we got, and I think which all of you may share your feedback on this, is that no matter how structured tool we have for assessing and the whole neuropsych battery, or starting from as basic as the mini cog HMSC going to the neuropsych battery. At Nimans, we used to use the Nimans battery. There is Scantab, the PGI, everything. But the problem is that the socio-cultural connotations are very important. I mean, I have my urban practice and community practice. You go to the rural areas, and one fine day you make somebody sit and try asking him or her, what is this? Show pictures, tell them to draw. It's a chaos. So automatically, you will never get to know that if you always use a very structured format. As Dr. Idris was mentioning, I think GPs or family physicians are the sole point through which a lot of us, can go to early detection. So tools like Minicog, clock drawing in educated individuals, simply naming or, using a modified version of that is HMSC that we use, that goes a long way, especially if we want to maintain some records. But when the load is high, you have to quickly understand whether a cognitive decline has set in, it's, I think, clinical examination and understanding and a parallel account from a reliable caregiver is the key. So nothing beats that. The tools are only to complement what we get through that and to substantiate in clinics, research, and specialized units. They are not really ways to diagnose a person with dementia.
That's a very important point, I think, because this is also for the family members, because they feel that, okay, there is one thing like a blood test, you do it and you know that whether we have Alzheimer's or not. But it is a much more extensive investigation that we do. We understand how the person was pre-morbidly and when did the problem started showing up, what was the pattern, what is the socio-cultural context, everything. And then and the tools aid in understanding where they are. So Archana,
Ananya, sorry, just one point. I think when I joined, Dr. Idris was mentioning this. The moment somebody comes to us with forgetfulness, immediately doesn't mean that a person is going to have dementia, irrespective of the age. It can be due to attention, aging, very commonly depression. Most of older individuals whom we treat depression, actually, the memory problems improve quite a lot. So I would rather say to all the people listening out to us today is that if you have forgetfulness, you visit the physician, seek advice, seek help, but don't immediately get tensed and worried that if it is an incurable progressive illness. There are thousands of things that can lead to forgetfulness. I just thought of mentioning that. Sorry to interrupt you.
Right. No. I think that's a very important point, because also the fear, like I recently have come across many people post-COVID, they had, like, it's difficult to say whether it's post-COVID or not, but some people started having some cognitive dysfunction, some memory deterioration, and they attributed a lot to, okay, this is my brain fogging after COVID, and that's a self-diagnosis they are doing. And even if you ask them and motivate them to, why don't you go and check it and talk to a neuropsychiatrist or your physician and just do a screening, it is often the fear that what if actually it is Alzheimer's. I don't want to get through that. I am happy within this space that, okay, probably it is COVID related, it will get better in some time. So I think that's a very important point that you highlighted, that it is, if you notice something, get yourself checked, but don't be pulling yourself back because of the fear that it might be something incurable, because we have medicines now. It may not be curable. I don't know how many disease we actually have cure per se, but we can arrest the progress, which is more important. And the earlier we do it, the better. So thank you, Debanjan, for mentioning that. I was also asking Archana, I know Archana had done a lot of neuropsychiatric assessments in NIMHANS. So what is your understanding, how was the experience like, the findings, how do they help in understanding the presentation of Alzheimer's?
So Dr. Ananya, with my experience so far, the neuropsychological assessments when we do with an Alzheimer's per se, it's not just used to identify whether the person has this particular disease or not. Sometimes neuropsychological assessments do help us to identify what are the strengths the client right now is having, and how we can use that to improvise the other impaired parts. So in that way, even for the rehabilitation part, of course, that also comes back to that, we do an assessments to identify the strengths, and using that will help us to plan the cognitive retraining for a client. So that's how the neuropsychological assessments do play a role other than the diagnosis per se.
Right. Thank you, Archana, because I think it is also important for the audience to understand that the neuropsychiatric or the neuropsychological assessments are not just done for understanding, just aiding the diagnosis. It is also done to understand what your strengths are. It helps in planning intervention. So it is very essential. Dr. Debanjan, what are the medical interventions typically what are the medical interventions available for Alzheimer's?
Yeah, so in terms of, treatment, of course, as I mentioned, that there are medicines and there are non-medical ways of addressing. I mean, non-medical ways we'll be discussing separately. I'll just talk about the medical interventions. So medicines are necessary for two things. One, as many of you mentioned, slowing down the progression of the illness. and two, controlling the behavioral symptoms, what we call as the behavioral and psychological symptoms of dementia, that is BPSD. With regards to managing BPSD with medicines, the success is quite high. The behavior, many of the behavioral issues like wandering, agitation, paranoia, hallucinatory behavior, eating problems, sleeping concerns, sundowning, that is worsening of issues post in the evening, are quite well managed. Apathy is something which does have medications, but again, they are not very effective. Though apathy kind of falls more among the negative symptom domain, that's one of the very important source of distress to the caregivers. With regards to slowing down the progression of illness, we have very limited choice of medications. And I would actually suggest that discuss the medical options with your physician, with your doctor, know about the side effects, how long to continue, how frequently do you need to get checked, whether any additional blood tests are necessary, because many times vitamin B12, thyroid, vitamin D deficiency can contribute to forgetfulness as well. There is a very common myth, I think you were discussing about myths that time, that not only related to dementia, in general, mental health medications or psychotropics or psychiatric medications are harmful to the brain. So again, that's of course a very harmful myth. And stopping the medicines without discussion with your doctor is really not recommended, because many times the micro gains that we have, so for an illness like Alzheimer's, which proceeds for years, even delaying the progression by 6 months or 1 year means an immense benefit. So I actually tell, the patients and their caregivers that, look, the way he or she is now, if I am able to see them like this after 1 year, I will consider that as a therapeutic success. If she or she improves, that's a bonus. So I think that's what needs to be considered, because if I always measure or weigh a person as to how much the person is improving in terms of reversal, then I will always feel that, there is no improvement. Also, I think the improvement more than in HMSC score needs to be in the daily function. Somebody may have a score of 20 getting up to 23, but whether that transits to a person being able to have their own food and find the toilet is what is more important and of concern to the caregivers. Like any other medicines, these medication can also have certain permutation combinations, certain side effects, but it's important that at each step, preferably at each follow-up 1 month to 3 months, that is discussed with the physician. And if you have any concerns or side effects, rather than stopping the medicines, it's always better to get it clarified, not by Google, but by your doctor.
I think this is a very important thing, again, that you highlighted, that setting expectations from the treatment is very important, because what also happens is when caregivers have a certain expectation and they don't see that kind of change happening, they immediately go to another doctor. So they don't continue with the treatment. They are expecting quick results, so they keep on moving from one doctor to another. And usually that also like it can have multiple effects, but one of the effects is like the progress, that like when somebody starts with a particular treatment, they might have something in their mind, and that again changing the process, again going through the entire assessment, that also gets affected. So sometimes knowing what exactly to expect, what the treatment process should look like, helps caregivers, one, make an informed choice, what to do and what to expect and what to do next also. If we are not seeing this, what exactly, where can I come back and discuss it with my psychiatrist? And can I tell that, okay, this is what I'm expecting, this is not happening? And also in this case, situation, I think psychoeducation about Alzheimer's is also very important
Very
for
important.
the caregivers.
And the other thing that I mentioned before is that, thank you for pointing this out. And I think this is a very common help-seeking habit, that a lot of physicians are changed and many medications are actually added. So when a brain is shrinking in size, when a person's cognitive abilities are deteriorating, all that we need a lesser number of pills, not more. So optimizing medication, I think, becomes extremely important. The solution is not in giving a high dose or giving multiple medications to bring them out. Rather, since Alzheimer's affects people mostly in their older age, you pull one string and hundreds get loosened. So, we have to take care of the metabolic parameters, the sugars, the BP, prostate, pain, constipation, thousands of things. So the lesser medicines, the better it is, because polypharmacy, medicine interactions can also lead to further worsening of memory and other abilities.
Right, right. So that is a very important point. I think whoever is listening to us, like these are things we don't talk about when we talk about Alzheimer's, but these are very, very essential points to remember. Archana, you just highlighted about, how neuropsychiatric assessment helps, neuropsychological assessment helps in understanding the strengths of a patient. So what are the typical neuropsychological interventions that are planned for patients with Alzheimer's?
So, Dr. Ananya, before going into a very narrowed on what the neuropsychological things that we do, rehabilitation we do, I would like to bring up the point like even with the neuropsychological rehabilitation, it is always an integrated approach. It's a collaborative approach because we do need to understand why the client is having such issues. So when we do a neuropsychological assessments, other than identifying the strengths, we do also need to give awareness to the caregiver. See, these are his strengths right now. These are his weakness right now. So building an awareness on that is one of the primary goals. And it's always a collaborative approach. We do work with clients directly, but then it's important that family members are also involved, because certain things that we do for cognitive retraining, if we are planning, then other than having a therapist, the discussions going back and the client might have to do some of it. So we do involve the family members also in the process of rehabilitation. And other than that, what are the other things we do is a cognitive stimulation. So cognitive stimulation is one thing where we will help the client to stimulate the issues. What are the tasks they have and issues with? We will set a goal and we will constantly remind them. There's a technique called a reality orientation, which is the information is about an ADL functions is given frequently so that the client can remember, or it is also categorized on a major theme so that the client can understand it and work on it. However, this is also be done along with the family members or a caregiver. That's one. The second thing with the cognitive retraining part, it is very personalized for a client to client. The only goal for a cognitive retraining is help the client to be as independent they can be. So, and which means like with whatever if they have a cognitive issues, we do use certain mnemonics kind of an activity to help them to understand and mostly make them independent, work on with their ADL functions. And as I said, it's based on each person. And it's also a very collaborative approach. Yeah.
Right. Thank you, Archana, for highlighting the need for collaborative approach. So the more we are discussing, I think what is also coming up is the importance of involving caregivers in the intervention program. So it is not just about the doctor and the patient. It is also about the doctor, the patient, and the caregiver, and that forms the ecosystem of intervention. Shayantini, we were also coming up with some of the behavioral aspects, right? How do you think, when psychologically speaking, what are the typical interventions for addressing the behavioral symptoms of patients with Alzheimer's?
Yeah. Archana has very nicely summarized the neuropsychological rehabilitation, and I completely agree with her. It is very like a personalized program. But when it comes to the psychological and the behavioral aspects, as a therapist, mostly initially we can start with cognitive behavior therapy, but it stops working as the stage progresses, obviously. We can focus on like emotion focused therapy, sensory stimulation therapies, and obviously behavior management. The emotion focused therapy mostly basically focuses on the emotional validation, reflective listening, certain grounding and calming techniques of the psychological and behavioral issues. Sensory therapies like a little bit of multisensorial approach we follow, like art therapy, music therapy, aromatherapy, etc. like that. Specifically for the behavioral issues and behavioral management, I will tell my audience ki any behavioral issues you are seeing in a Alzheimer's patient, ask yourself first 3 questions. What happened right before the behavior happened? We call it as ABC model. That is, you must identify the triggers first, that what is causing the behavior. Many triggers we have already discussed in the causal factors of the behavioral issues. If the patient is unable to communicate, sometimes we use pictures. Like we use for autism kids also, picture exchange communication system, where suppose some options we are given and the patient had to point out what is causing him distress. Then second question is, how did the environment or you reacted to the behavior? How is your reaction? Because if you also get very angry and resistance and resistance will collide. So it will give a null conclusion. So you have to be very calm. We are coming to the third point, that what can you do to reduce it? So you have to be very calm and patient while dealing with the patient, and talk with very respect and dignity. In behavioral therapies, we arrange certain reinforcement schedules, like activity schedules we prepare for patients. But as a caregiver to the audience, I can say you can follow sometimes the C3P model, which we say as first is change the person, then change the people, and then change the place. Change the person means if suppose the person is feeling a little bit hungry, tired, hot, cold, after figuring out the reason, then you can approach to the solution in a different manner. The people will look at your own behavior, that if we accidentally did something to trigger the behavior, change the place means see the environment around the person, that if it is too noisy or a little bit of disturbing environment, here just remember one thing, what is disturbing to him or her or they may not be disturbing to you. Like I had one patient who specifically used to get very agitated and started crying 3 p.m., 4 p.m. in the afternoon hour. So after doing the detailed behavioral analysis, we came to know within that time, his grandchildren used to come from school. They have like loud noises, jumping there, and increasing the TV volume, etc. So that was a little bit causing the patient a little bit distress. So what the caregiver did after discussion, that he shifted the person to some other room where for that period of time, he can be a little bit calm and peaceful pace. And also, like for any kind of task, which Archana also mentioned, that simplify the task for the patient, break down the task, because you have to use a lot of systematic cueing, verbal cueing, visual cueing, physical cueing. Give them very simple choices so that they can understand you and communicate with you. Sometimes, if the situation worsens and they start having psychotic symptoms, I say one line to my patient, ki connect with them, do not correct them. Do not challenge them every time when they are having those delusion hallucinations. Try to solutions delving into their world, and sometimes try to divert or distract from those which bothering them to a particular thing which are enjoyable and very likable to them. And always give that comfortable, safe, and reassuring space to them so that they feel accepted. Because whenever I talk about rehabilitation, one book I have read, I don't know whether you all have read the book of Nicholas Sparks' Notebook. It's a very famous book. I really like the way the husband handled the wife. So advice to you, handle that person like a sweet child. Take care of him or them. Every day is a learning and relearning. for them.
Thank you, Shantini. I think that was a very powerful statement, like connect with the patient, not correct them. And, it also helps us understand that there might be some of the cognitive symptoms which might take time to to see any kind of improvement, but these behavioral issues can be managed with a little bit of understanding, a little bit of compassion, and a little bit of curiosity. So I wish we had more time. We have already crossed our time, so I think we are on the verge of almost wrapping up, although there are so many areas and so many domains we still would like to cover. So now that we have come to the end, and I think by this end, we have got a fair picture of what it is to be a patient with Alzheimer's, to be a caregiver to a patient with Alzheimer's, and to be a doctor or mental health professional to a patient with Alzheimer's. So now that we've come to the end, I would like each of you to say any one parting advice, anything that you think that the audience can take back from. And I think we can start with Dr. Debanjan, knowing that he has another OPD to attend and he will probably be leaving very soon.
Thank you, Ananda. I would give two parting comments with your permission. So one is, of course, I was hearing Shantini speak, and it's a very powerful message. Thank you. I always put it in this way that we have to go and live in their world. They will not live in us. So islands of memories are preserved. I remember, many of my patients whom I know, they are going to their office, they are living their adulthood, childhood. So we have to fit ourselves in their islands. We can't expect them to come in us. That would be one. The second is, I know that we have discussed many concerning factors, and not to scare anybody, dementia may be a progressive illness, but as I started, mentioning, not all is that grim. Today we know that there are more than 10 modifiable risk factors throughout the life, from early to late. And if you consider all of them, education, keeping the brain active, physical activity, hearing is a very important thing, correcting hearing loss, diabetes, hypertension control, weight control, cutting down on alcohol and smoking, and increasing cognitive and physically stimulatory leisure activities. I think all of these taken into account, 40% of dementia risk can be cut down. This is highlighted by the Lancet Commission's report on Alzheimer's published in 2021. And that itself shows us the capacity of prevention in lifestyle illnesses. So I'd like to end with that positive note, that a lot can be done to be prevented.
Thank you, Dr. Debanjan, for that.
Thank you for having me here. It's always a pleasure.
Thank you. I know despite your very busy schedule, you managed to take out some time for us. So thank you very much, and leaving us with a very positive message and a lot of hope. Thank you. Moving over to Dr. Idris.
Thank you, Dr. Debanjan, and thank you, Dr. Anya, for this wonderful exchange of ideas and information. Like you rightly said, that there's a lot more to speak, but yes, we have to stop somewhere. So since Dr. Debanjan has already covered the medical aspect of it, I think I would like to touch upon the fact that it's really important that we start working as a team rather than working in silos. Working with multiple specialties where it is definitely required for us to support the whole ecosystem with the patient and the caregiver as well. So many times when I deal with caregivers, I often tend to, come down to explain things to them in a much simpler fashion. I usually tell them that imagine that you are in a movie, your life is a movie, and there comes a stage where faces of your movie are just blank, and you don't know why. So that's trying to put them into the shoes of the person suffering from this condition. So it's difficult. It's difficult because they have had a relationship with a person, and you have this physical person with you, but the personality is not around you the way it used to be. So to accept that fact, it's going to be challenging. And it will not go away with 1 or 2 or 3 sessions of us showing them the mirror. I think it has to be consistently done over a period of time with the multiple people who are involved in the care process, the family physician, the psychiatrist, the psychosocial therapist. And one important aspect to which I think we are still a bit lacking in India is occupational therapy, wherein we try to make things around the person suitable to that person. That's something which I think we can focus on. That's something which is still underdeveloped. We can do a lot more to make things easier for people with dementia, with people with forgetfulness, people with when dealing with people who are at the extremes of age, because they are a sensitive population. So that's one thing, and I think talking about things is the first step, which we have made a start today. Making this discussion common with family members, with people who are reaching that phase of life, before they actually get there. So I would just like to put in one small sentence with respect to the legal aspect, which we think we have to discuss, but we didn't have time. If we are able to fix these issues earlier, the whole legal aspect of this could be easier to manage. How they can make the decisions, who they give the power of attorney to in the family, who can make decisions for them. All these are preparing things for if things go bad. But if we don't see it happening, we never get there. So talking about it is most important. Making people aware of it, getting the multidisciplinary team set up for this is really important. Than working as a silo. And polypharmacy, like Dr. Deban has already mentioned, that's another major aspect of our care, which we see especially very common in India, unfortunately. And all these have to be handled at the right time. So I would end with the note that having the right information is more important than having more information. So look for the right information and make sure that we try to get that and implement that in our practice and our whole social structure as such around us as well, because we are not doctors only in our clinics. We are also health professionals in our social gatherings, weddings and parties. We get asked questions, so we hit the right chord even there. Thank you.
Thank you, Dr. Idris. It was an honor to have you as a part of the panel, and thank you for making out time for this panel and emphatically reiterating the need for an integrative approach. Like the topic today is also like looking at Alzheimer's through a holistic lens. I think that is something we could achieve through this discussion, that we have been able to understand Alzheimer's through a holistic lens, and you have very beautifully highlighted the need for an integrative approach and the need for continuing our role as ones who are providing awareness. It does not only limit ourselves only to programs like this, but anywhere and everywhere. Like you very rightly said that we are health professionals everywhere, right? We go to a wedding where people always have questions, but that also gives us opportunities to clear doubt, to psychoeducate them, and to create awareness. So thank you for all your words of wisdom, and particularly for highlighting the legal part. For time constraints, we couldn't cover that question, but it is very important. So we also see that, at the moment the diagnosis is done, why the diagnosis is important, because it does not help only in the symptom, it does not help in addressing the symptom, but it also helps in taking certain decisions which will inevitably be important and essential for the person's life. So thank you, Dr. Idris, for highlighting that. Coming over to Archana, your last words of wisdom.
We have addressed many things, but one thing which I would like to tell to the people who are watching is the social inclusion is one of the key aspects that would help the people with Alzheimer's disease to grow. That's one of the support systems that the society can offer. And that will help the family also, that, okay, fine, like I'm in the society where I'm also included, can destigmatize the Alzheimer's and help the people to grow. Is one thing I would like to end with.
It is so important. It is so important because, like Shayantani was also mentioning, that there are so many losses, and one of them, like, I was like this, and now this is how people are treating me. It's not only what I'm not being able to do, this is how people are treating me. So inclusivity is a value. And inclusivity is also a very important aspect to be taken when you are looking at policy development, also how we are equipping our environment for patients with dementia. What are the things we are doing? So these are, thoughts we need to always keep in mind. And I think awareness and discussion like this always stimulate people to think in these lines and see what are the things we can do. So thank you, Archana, for being a part of the panel and for highlighting such important aspects. Particularly, I think the neuropsychological aspects is something people often have, like they dread it. Sometimes they have a lot of misconceptions about it. They think, okay, what am I going to get? Am I going to get a report which will say everything? You clarified it so well, and most importantly, identified the importance of social inclusivity, which often I think in discussions like this is the first time actually this thing had been told. So that thank you for bringing this up. Thanks, Archana. And lastly, Shantani.
Yeah, everyone has said everything, but yeah, one thing I would like to agree with Dr. Debanjan when he talked about rural areas. A lack of facilities, lack of multidisciplinary approach is actually lacking in the rural areas. So we should take an initiative to do something. And also my message to the caregivers that take care of your health also, because due to lack of time, we couldn't talk about you, sorry. Take care of your mental health, take care of your physical health, because if you are not doing well, you will not be able to take care of others. So yeah, I remember a very famous poem of Kamini Roy. It's in Bengali that "Shokole store shokole amra proত্যেকে আমরা পরের তরে." So we are there for each other. So yes, life is beautiful. Be happy, be human, be kind.
Thank you, Shantani, for very in a very crisp way summarizing a very important point that we often keep our focus so much on the patient that we forget about the ones who are taking care of the patient. Caregiver burden is real. Caregiver burden is a reality, particularly for patients with dementia and Alzheimer's. Like, it is more about they also see a huge shift. They can't make sense, like, this is my father who was doing so well. Why is he forgetting? Like the whys and why me and all the things, it impacts. It doesn't not only impacts these things, like the way that's seen their close ones, it also impacts their day-to-day functioning, how their life shifts. Sometimes many decisions need to be taken because a close one has been diagnosed with Alzheimer's. So it is very important that caregivers also recognize, okay, I might have some impact because of this caregiving, and I also need to seek help if required, or at least take care of my mental health as much as possible. So thank you, Shantani, for, I know you had not been well for quite some time, but I'm so glad that you could be a part of this panel and enrich us with a very compassionate lens of looking at patients with Alzheimer's and also the caregivers to the patients. And with this, we come to the end of our very fruitful discussion. And I think all we are going out with is a better understanding, a better awareness, and a lot of hope. There's so much that can be done, and it all links you for you to come and seek that support. So thank you, IJCP and MedTalks, for organizing this, for involving Therapy as a part of this very important discussion and helping us reach out to such a large audience. And thank you, everyone, for joining this panel. Thank you for the audience for spending time in being a part of this discussion. If you have any questions, you can write it in the chat box. We will take one or two questions. I think we're very much out of time, so you can maximum take one question if there's any. Otherwise, we will conclude the session. Thank you so much. Faraz, are there
Yes,
any
ma'am.
questions?
Yeah, I have just checked, ma'am. There is no more question. I thought that this session has been so explainable that all the doubts of this topic has been clear to all the participants who have joined this session.
Right. Thank you so much. Then that's very, I'm glad that we could reach out to people and clarify some of the doubts that they had. So thank you. Have a great evening, and hope we can keep spreading this awareness and this hope for a very long time. Thank you.
Thank you so much, ma'am, everyone,
Thank
for
you.
joining
Thank
on
you so much.
IJCP platform. It was a really glad to have you all, as we know that the physical disease and physical problem is visible to each and everyone. But mental disorder is a kind of problem, is the person who is suffering from it only able to understand this problem. I hope this video is going to impactful on many lives and going to overcome from the problem like this. Thank you so much, and hope to see you again with different topic in coming times. Take care, everyone. Bye bye.
Thank you.